Hey everyone, I'm Dr. Moore, and I'm going to be talking about ultrasound and systemic sclerosis. This should be about 15 minutes or so, and then Dr. Richardson and I will answer questions. So I do not have any pertinent disclosures, and you may notice on that very first title slide, there's this RHMSUS abbreviation, so to speak, and that's a title. It's a certification program the American College of Rheumatology sponsors, where basically rheumatologists can get certified in the performance and interpretation of musculoskeletal ultrasound, both for diagnostic purposes and interventional purposes, guiding procedures. So we'll talk more about that a little bit in the visit, but just in case you're wondering what that abbreviation was. In terms of objectives for this talk, it's pretty straightforward. We're basically just going to talk a little bit about what ultrasound is, why we might use it, what its advantages are, talk about how we use ultrasound in the evaluation of scleroderma-related scleroderma, but also scleroderma-related musculoskeletal conditions. And then, outside of the musculoskeletal system itself, how do we use ultrasound to assess the other domains of scleroderma involvement, such as skin and the lungs? Because, of course, scleroderma it's not just scleroderma, right? It's systemic sclerosis. It affects many tissues besides the skin. So, ultrasound, what is it? Essentially, ultrasound is one of our 4 chief imaging modalities, procedures, you could say. We have plain X-rays, we have CT scans, which are essentially 3D X-rays. We have MRIs, which do not use radiation at all, and then we have ultrasound, which also does not use radiation. It uses sound at an ultra-high frequency, and these are inaudible sound waves that basically this device called a transducer, it sends the sound waves out. The sound waves bounce back off of structures, and depending on what that structure is, what its density is, how deep it is, they echo back. It's kind of like radar. They echo back in a certain way. The machine interprets it all, synthesizes it together, and ultimately it generates an image, like you see at the bottom of the screen here. And this image might just kind of look like shades of gray to you guys, but essentially there are some key features here that to the trained eye make sense right away. There's this rim of bone here. This is the skin up top. And in between, of course, are all the different tissues of interest. How thick is that skin, but also the tendons. And right here where I'm motioning with the pointer, that's what's called synovium. So that's the tissue that supports the joint, nourishes the joint, but also when we have autoimmune arthritis that's damaging the joint and causing things like this little erosion here, this little chewed out portion of the bone, that's actually where those cells are proliferating and propagating. And so that is something that we can see in real time right there with ultrasound. Typically, though, ultrasound is performed by a technician, and then it's interpreted later by a radiologist, either in the next room or sometimes halfway around the world. So why do we use ultrasound? Well, it's cheap, it's easy, it's quick. Essentially, there's no reason you can't do an ultrasound on a patient other than literally the surface you're trying to examine is, well, there's no skin on it, it's a wound or something. Essentially, other than that, anyone can get an ultrasound. Now, ultrasound can't go examine every structure, right? It can only go so deep with such fidelity, but there really is no true contraindication to an ultrasound exam. It's also a dynamic exam. It's not just a single picture. You can actually actively move a joint or a structure that is impinged or getting hung up on something, and you can watch that on the screen and give that immediate mechanistic insight, so a dynamic evaluation. And then, of course, all of this, ultrasound, great, but what does that have to do with you, Duncan, a rheumatologist? I can actually do ultrasound at the point of care, right there in the room with you, and that can immediately impact our care plan or guide a procedure. And so that is really why some rheumatologists have sought training in this. It is extra training. It takes time. There's a cost to that, but it can be quite helpful. So why do we use it in systemic sclerosis specifically? Well, this first point is sort of the point of any rheumatologist using musculoskeletal ultrasound at the point of care, is to detect and define musculoskeletal manifestations of scleroderma or its related features, related diseases. But I think the big question that a lot of people have about scleroderma and ultrasound is, okay, well, skin is a very superficial structure, and we want to examine it with greater detail and granularity and quantification. So can we measure skin thickness? Can ultrasound help us do that in a way that's clinically meaningful? There's actually been a fair amount of research in using ultrasound to detect scleroderma-related lung disease because you have ribs in the way, but in between the ribs, you can look into the lungs with an ultrasound. And then, Dr. Richardson was talking a little bit about calcinosis, entirely about calcinosis, and ultrasound has some role in that, in detection and targeting it. So, to delve into each one of these briefly, musculoskeletal disease manifestations in scleroderma. So, the exam of joints in scleroderma can be difficult, particularly if the skin overlying it is thickened, or if the skin thickening has caused kind of structural deviations that it's just, to your average rheumatologist who is well experienced in the exam, a scleroderma joint exam is still can be quite challenging. And we know hand pain is very common in scleroderma, and so hopefully, ultrasound can help us delve into this further. There, kind of canonically, we say that autoimmune arthritis, inflammatory arthritis, is thought of as relatively uncommon in scleroderma. But I think one point I wanted to emphasize today is I think that is underdiagnosed. People say 5% of patients have it. Well, there's a couple studies that have used ultrasound to assess this question, and there's this first study here in 2012. Clinically, the rheumatologists at this center thought that 15% of their patients had inflammatory arthritis, synovitis, that swelling of that tissue that I showed you on that slide earlier. But actually, 46% of the patients actually had that swelling when you looked on exam, and I think that speaks to the degree to which the skin thickening can sometimes make this challenging. A different study at a different center said 25% and 52% respectively, but kind of a similar theme there. So, hand pain, though, not all hand pain in scleroderma is the skin thickening or autoimmune arthritis. Actually, osteoarthritis is very common in scleroderma. And so on these images here, 1, 2, 3, the top one is a normal ultrasound picture of this joint, the kind of underside of what's called a distal interphalangeal joint. And that's a normal one up top. You see there's bone, that little space in between is the joint. It all looks normal. The next one, there are bone spurs here and here, and those are called osteophytes, and those are sort of those are the characteristic feature of osteoarthritis. It's not an autoimmune disease, right? It's a common, we call it a degenerative arthritis. We don't really understand, despite it being so common, we don't really understand what causes it, and we have no way to prevent it in a non-weight-bearing joint. But the point is it's there. It's ubiquitous in patients, and the question is it driving your symptoms? And then in this third picture here, we actually see a much bigger bone spurs. Again, the space where the joint's supposed to be, there's all this extra bone there, and there's actually a little bit of inflammation. This is extra blood flow on the ultrasound. We can see increased blood flow on what's called Doppler ultrasound. And that blood flow is really because of that very vigorous kind of local reaction to those bone spurs. It's a mechanical issue. And so there is a study by Dr. Fairchild at Stanford. He specializes in scleroderma and ultrasound. And basically 50% of the patients at that Stanford study had significant osteophytes, bone spurs, on ultrasound exam. And there was a very high concordance of kind of the burden of osteophyte at a specific joint with the tenderness and the swelling. And in his study, it wasn't 50% of patients had inflammatory arthritis on ultrasound, it was 20%. And I think the reality is some of those other studies were probably conflating a little bit of osteoarthritis with inflammatory arthritis. Okay, so other causes of hand pain and scleroderma in which ultrasound might be helpful. Carpal tunnel syndrome is often seen, particularly early on in scleroderma, when you're in that more edematous kind of swelling phase particularly. Sometimes it's even the first sign of scleroderma in retrospect. And essentially carpal tunnel syndrome is you have your median nerve and a bunch of tendons going through a tight canal of bone in your underside of your wrist, and basically when that nerve gets pinched, you get shooting pain or weakness, tingling in your fingers. And so, it's common in scleroderma. There was an interesting small study by a single physician, I believe it was in France, who basically took 12 of his scleroderma patients and who had carpal tunnel-like symptoms, and under ultrasound guidance went in there with a needle. This is the median nerve. Basically went in under ultrasound guidance right to around this nerve and injected saline and steroid that sort of loosened up adhesions. And we give steroid injections to treat carpal tunnel syndrome sometimes, but essentially this is a little different because there was really what's called hydrodissection, where they really took time to kind of open up things in there by spreading fluid around. And basically, it's not a controlled study. Like Dr. Richardson was saying, there really is a profound lack of good quality evidence in most questions in this disease. But about 2/3 of the patients had a significant improvement in their pain, and actually, even more surprising, I think, to me, is that a even larger number, about 8 out of 10, had improvement in their Raynaud's phenomenon and their the digital ulcerations. And the author essentially is hypothesizing that the degree to which there might be stricture or entrapment in scleroderma, and kind of essentially going in there and kind of breaking it up a little bit, particularly earlier on in the disease, was driving that clinical improvement. And there can also be vasospasm of your larger arteries in your wrist, before they go out into your fingers. And so by reducing the spasm at that level too, it seems to have helped with the issues with the digital ulceration by basically opening up the pipe closer to the heart. So let's pivot a little bit. Let's talk about skin thickening, right? Because, of course, we think of skin thickening as sort of the cardinal feature it is the cardinal feature of scleroderma. And, one challenge with using it as a primary outcome in a trial or a main proxy for how bad is your scleroderma or how much is it progressing is that the actual clinical assessment, the Rodnan skin score where we pinch your skin, it's really variable between different examiners. It's variable even from the same examiner from day to day, or even if you pinch the same area a few times, the exam can change a little bit. So there's a hope that by using a machine that can very kind of granularly measure thickening, that we can be more precise as we use skin thickening as an outcome measure. On this top one, this is normal thickness skin. This is scleroderma skin. So you can see these two little calipers, these two little measurements. Essentially, we're talking about very small differences here. But actually, there have been a fair number of treatment trials, and there are ongoing treatment trials. We were just discussing participating as a site in a trial where they were asking us, what are your capabilities for ultrasound? Can you do these measurements? This is a trial from 2 years ago of Xeljanz versus methotrexate. One of the outcomes they looked at was skin thickening at 1 year. The numbers we're talking about here are very small, right? We're talking about an improvement of 0.3 millimeters versus 0.08 millimeters. It's profoundly small differences. Obviously nothing you could detect on a clinical exam in any sort of granular way. It'd have to be more of a gestalt. But there are statistically significant differences with different treatments, and then that I think shows that we can use ultrasound. And when we use ultrasound to make these measurements, it's actually very reliable from different examiner to different examiner or from exam to exam. It's far more reliable than our skin pinching Rodnan skin score. But essentially, that's kind of all we know. Every study checks a different number of sites. Every study has different thresholds for what is thick or what is normal. They're all using different machines in different eras. This technology has changed a lot over the last 10 years, let alone the last 3. And so all these questions I list here, these are questions that are not answered or standardized in any way. It's completely, basically ad hoc from study to study. There is a working group working on that, but it's still in progress. And this is just a summary article or two. It's actually the same author in 2019 looking at 2017 and before, and then in 2022 looking at 2021 and before. And you can basically, after 3 years, not much of a difference in the summary sentence here, but essentially I'll just draw your attention to we know we can make measurements, but the feasibility, the validity, the discrimination, meaning like is this diseased or not diseased, making those thresholds, deciding what are cut points for saying abnormal or not abnormal, and then also the question of is this clinically meaningful, right? It's going from 0.3 millimeter improvement versus 0.08 millimeter improvement. What does that mean for a patient? No one's looked at that in a bigger sense. So essentially, there's promise in the technology, but there's still zero standardization right now. So it's impossible really to compare study to study. Okay, so to pivot to thinking about scleroderma and ultrasound beyond the skin, beyond the joints, thinking briefly about lung disease, This image here is a picture, a CT scan image of interstitial lung disease. You can see there what's normally supposed to be black, meaning just normal air-filled lung. There are these different areas where there is fibrosis or thickening, and that's interstitial lung disease. And so on ultrasound, when you put a probe in between the ribs here and you look into this, you look into the actual lung, you'll see what are called B lines, so certain basically shadows, or you'll see certain changes in the pleura, which is that layer on the outside of your lungs. And so these are actually very reliable for saying, okay, is there autoimmune, interstitial lung disease, yes or no? But where this is, again, the same kind of questions we have with the skin. How does this compare to our gold standard of CT scan and pulmonary function tests? What settings are you using on your machine? How qualified is the person who's taking these pictures? And then also, more importantly, kind of longitudinally, is this useful for tracking the severity of your lung disease or watching it over time? Particularly that question is limited, compared to our current serial pulmonary function test, serial CT scans. So it raises interesting questions, but a similar kind of summary sentence from this review article from a year or two ago basically saying there's promise, but it's not widely used or standardized yet, and we need to do that before we can really say one way or the other how useful it is. And then last major content slide here is basically calcinosis. So like Dr. Richardson was saying, sometimes the calcinosis is right there. It's in front of you. It's right on the surface. You can feel it. Sometimes it's quite overt on the x-ray, but sometimes it's actually quite subtle. Or you've got kind of a lump in one or two places and you don't really know what it is, and maybe it's a little bit deeper. You can't see it. And so that's a case where, yes, you get an x-ray, that's fine. But, if you're there in the clinic with your doc and he or she can look with an ultrasound, that is also an opportunity to make that diagnosis right then and there. I actually did that last month with a new patient. But what you would see on ultrasound, so this is a finger pad. You essentially, either what happens is the sound waves can't go through the calcium, and so you get what's called shadowing behind it, acoustic shadowing. This black area, which should normally be like a white bone, there's a black area, and that's the calcinosis above that, blocking the sound waves. Or, like Dr. Richardson was saying, sometimes the calcinosis is much more kind of heterogeneous or kind of more liquidy, and the sound waves are actually able to get all the way through, and this, where the little arrows are pointing here, is also a calcinosis blob. And so particularly in deeper structures or within the muscle, ultrasound can help us right away know that. And it also, there was a study here, a case series rather, a single physician in 5 patients with scleroderma and calcinosis used ultrasound to find lesions, inject the sodium thiosulfate directly into it, and then re-image it a few weeks later and show complete resolution or near resolution of certain calcinosis nodules. So I think, it is to kind of summarize in calcinosis, but also more in general, ultrasound is an adjunct for diagnosis. It can guide procedures. It can enhance your physical exam. But there are, it is not widely used because, frankly, not a lot of rheumatologists are trained in it, and there's a cost to the training, right? It takes time. You have to have a machine, which can cost a fair amount of money. You need to have, it's essentially a one-to-one apprenticeship for a year to learn how to do this, and so it's just ultrasound in rheumatology, but also particularly in scleroderma is really in its very earliest days still. So to summarize beyond what I just said, ultrasound, it's quick, it's affordable, accessible, you can do it right there in the clinic, piece of cake, if you're trained. And it has a lot of different uses in terms of what it can diagnose. Rheumatologic conditions, including scleroderma, point-of-care ultrasound can tell us what is going on in this joint that hurts, and you can start talking about that right there the next minute with your rheumatologist. Generally, like I said, inflammatory arthritis, I believe, is underdiagnosed in scleroderma. I think it is more than 5%. And yeah, the idea that 20% of our patients have it, as Dr. Fairchild found, that sounds right to me. Osteoarthritis, of course, is common. It's common in everyone, but when it's present and you have scleroderma, that can complicate the assessment. So that is something we can also determine from x-rays, but also dynamically on ultrasound. Ultrasound guidance can improve our performance of procedures and allow us to do procedures we wouldn't otherwise be able to do blindly by landmarks. And big picture, when we think about using ultrasound to diagnose anything beyond what's going on in the joint, basically beyond what is standardized for use in other rheumatologic diseases, it's a complete blank slate, basically, in terms of any degree of standardization with respect to skin thickness or lung ultrasound. But I think there's enough interest from people organizing and performing trials, the idea that soon we will be able to use ultrasound by people who have received just essentially a cursory training. We'll say you're going to check these 5 spots, you're going to put the machine with this much gel, and you're going to hold still and take this picture with these settings. That, I think, is very feasible. I think you could train a dozen rheumatologists in an afternoon, to go back to their sites and do that. So I think we will continue to use ultrasound in trials, and I think it will eventually be a useful, widely deployable adjunct. We're just still working on standardizing it. So, okay, here's some references, and I think at this point, why don't we do some questions?
I don't know exactly how to answer this because you kind of went to it with underdiagnosis of inflammatory arthritis. Some of the pictures that you showed, like in the hips, mm-hmm. Is there people may have difficulty saying it's without a diagnosis, inflammatory arthritis or something like calcinosis in the pelvic region? I mean, it seems like the similarities are there for one person to think, well, it's just arthritis when it could actually be calcinosis.
Oh my gosh, that's a fabulous point. And so inflammatory arthritis in the hip joints is notoriously difficult to identify. People get hip replacements before they get a diagnosis of inflammatory arthritis in the hips, right? Because an MRI doesn't always tell you whether it's inflammation, and it's a very difficult, you can't really feel, it's so deep, right? It's covered by all these structures. And I think the other element is the hip joints are surrounded by tendons. They're they bear a lot of weight, they have a lot of mechanical loading. If those tendons are inflamed, sometimes we don't know. Another place that I think, to your point too, same thing in the spine. We know that people with calcinosis are more likely to have arthritis in the spine, right? So is there inflammation in the spine that we're not detecting that looks like osteoarthritis? Those are fabulous questions, and that is something rheumatologists struggle with. Is it wear and tear, or is it inflammation that we just can't detect, and we can't take a biopsy and we can't feel it? That is a great point. Yes.
Are there ongoing studies for calcinosis that people can volunteer biopsies for to help out?
So we need to get a protocol together because we don't have a protocol set up yet, but it is, we're looking at retrospective studies right now. But yes, we would love to have, and actually there's a lot of interest from our division chief too in doing that sort of translational work. So if you have osteoporosis and you think you have calcinosis, so typically the rheumatologist is the one who's going to be ordering x-rays and any other imaging that you might need. Any doctor can order x-rays, your primary can order x-rays too, and it is helpful. Typically we'll start with x-rays first of any areas and often people are the best at telling where they have calcinosis. So it's better than me examining is to say and people will pick up these small areas that are abnormal to them. So yeah, anyone can order x-rays, but usually the rheumatologist is the one who really does it.
Thank you.
Welcome. Yeah. Yes.
Does the standard bone density test identify or show display calcinosis?
Oh my gosh. My heart is just like leaping. So this is something we educate our rheumatologists on a lot. So you look at that patient with, calcinosis all around the hips. Now, if we do a bone density test, we're going to be measuring the bone in the hips and in the lower back. What if you have a ton of extra calcium there? What if you have a ton of extra bone? You can overestimate the bone density because you're measuring calcinosis, which is not going to help protect you from a fracture. You're not actually measuring the healthy bone that needs to protect you. So the standardized bone density test, if you actually look at the images, it's a low-dose x-ray, and it's not a high, it's doesn't have a high resolution as an x-ray, so it's not something we'd use to detect calcinosis. A plain x-ray would be better, but it's just something to keep in mind too, that if you have calcinosis around your hips or if you have osteoarthritis in your lower back, your bone density might be way overestimated. So sometimes you'll see people and it looks like your bones are, far better than the average 25-year-old. That seems a little improbable, right? And that often indicates to me that there's arthritis that's affecting the results. Yes?
Is calcinosis, would that, if one feels like, as if you're rubbing sand between your hands, whether it's in the wrists, in the ankles, in the upper torso, is that calcinosis? However, it does not appear on the skin. But when you touch yourself, it's like a grinding sensation. And I best describe it as picking up sand and rubbing it between your hands.
But deep?
Would that be calcinosis?
So the wrists, the hands would be commonly described. It seems funny to me that the x-ray wouldn't pick it up too, especially it may be like early inflammation that maybe, and again, maybe those small deposits that we're not seeing yet. But yeah, it can definitely cause discomfort with moving and, feeling like that deep kind of grinding sensation. I think about with that grinding sensation too, like tendons. Sometimes actually, if you move your tendons, people with scleroderma often have what we call tendon friction rubs, where there's literally, it just feels like crunching or cracking as you move your tendons.
And I'll say there's, the wrist has so many different structures at different layers. It really can be quite challenging to figure out what is driving your symptoms or your pain at any specific moment, and that is one advantage of the ultrasound, is that it's a kind of dynamic interaction of exam and diagnostic imaging at the same time that can help detect inflammation. Other imaging modality that is separated in time from your exam, whether it's a CT scan or an MRI, every image type has its own advantage and disadvantage, and it's tough. You really, at the end of the day, need a rheumatologist talking to you to synthesize it all and say, well, I think these one or more processes are driving your symptoms. So I'll just put that out there as often more than one thing is going on.
Yeah. Maybe one more question? Or if there are no questions, then we'll keep it. All right, thank you.